Now I need a little help from anyone. Can you see the first slide that says midterm quiz question review?
Yes.
Yes.
Okay, great. Thank you. So we'll start off by just a quick review of some of the questions that were on the quiz and try to do this as a way to underscore some of the points we thought were important but might not have been communicated effectively during the presentation, and I'll speak for myself during my presentation. So by way of this quick review, it's just trying to emphasize some of the points that might have gotten lost during the presentation. So we had one question that was about the prayer study, and the way Blackboard broke out the question, it turned out to be 4 separate questions about the prayer study. One question was, intercessory prayer was not effective. This is one of the results of this uh, gold standard study that was supposed to be the definitive way to determine whether or not prayer was effective from a scientific research perspective. So one question was, true or false question was, intercessory prayer was not effective, but the results of petitionary prayer in the group receiving prayer were statistically significant. Um, and that's false. There are 2 types of prayers that we reviewed. This was a slide from the presentation that I gave on prayer. Petitionary prayer is when you pray for yourself, and intercessory prayers is when one person would pray for another. It can be done in a non-distal way or a distal manner. And with regard to an intercessory prayer, you'll see this asterisk that says the effectiveness of intercessory prayer has been the subject of research and controversy. So this study by Herb Benson out of Harvard was about intercessory prayer. It was not about petitionary prayer. It was about individuals praying for others. And in this case, it was patients who were undergoing cardiac surgery. So there was nothing in there about petitionary prayer. So that's why that question was false. Intercessory prayer was not effective, but the results of petitionary prayer were statistically significant. Another question about the prayer study, true, false, intercessory prayer itself had no effect on complication-free recovery from the coronary artery bypass graft surgery. And that was true. This was an important outcome because everybody was waiting to see the results. Did prayer have an effect when these prayer warriors praying for patients, and in one group where the patients knew they were receiving prayer, another group where the patients did not know whether or not they were receiving prayer, but indeed prayer was given on their behalf, what were the results? And so this was a true outcome of the study, that intercessory prayer itself had no effect on complication-free recovery from the cardiac surgery. A lot of researchers who are um, interested in this outcome many were somewhat surprised that this was an outcome. And this was the slide that I gave during the presentation on prayer, with the conclusions of the prayer study. Intercessory prayer itself had no effect on complication-free recovery from coronary artery bypass graft surgery. And another question was, true or false question, the certainty of receiving prayer was associated with a higher percentage of complication. And as you can see from the previous slide, which is right here, underlined was another conclusion of that prayer study. The certainty of receiving intercessory prayer was associated with a higher incidence of complication. I think many researchers would have thought that there would have been a lower incidence of complications in the group. And the last question in the prayer study was that intercessory prayer decreased the number of complications the group prayed for compared to the group not receiving prayer, but failed to reach statistical significance. It was thrown in there to make you think. Uh, and as I said just a moment ago, this was um, false. Intercessory prayer did not decrease the number of complications, but in fact increased the number of complications. So in group number 3 of this study, these were patients who did have intercessory prayer, and they were told that they were going to be prayed for. They had a complication rate of 59% compared to the 2 other groups in that study. So the second bullet shows, in other words, those who were certain they were receiving prayer did worse than the 2 other groups in the study. And then we had a question about Heloise's story. You might recall the story. Uh, it was an audio file that was played. The question was, what mechanism in the biologic pathway model that theorizes why religion and spirituality is linked to better health is best depicted in Eloise's story? I'm not going to play the audio file, but again, it's about 3 minutes, but I'll just briefly summarize Eloise's story. This was a slide that I presented regarding religion and spirituality promoting resiliency. Resiliency is the ability to recover readily from illness, depression, adversity, or the like. When something is stretched but not broken, you think about a rubber band, right? You can stretch them really far, but if it's resilient, it will not break. Eloise's story is an example of resiliency through faith, hope, and optimism. Briefly, this is Heloise's story. She was in her mid-40s. She taught French in a small Midwestern town for over 20 years. She had a devoted husband and a son who just finished college. She was defined as a mover and shaker in her community, serving on several boards. She was a pious Christian, extremely active in her Episcopal church, and her family was healthy and well-to-do. She was a contented individual. Her friends said she lived a charmed life. Well, her life changes. In less than a year, one tragedy after another befell her family. She was diagnosed with multiple sclerosis and had to stop teaching high school. Her husband's business went bankrupt and she committed suicide. Her son overdosed on drugs and required residential rehab, and her mother died of cancer. But despite those hardships, Heloise had a remarkable and unwavering spirit of optimism, which was attributable to her strong religious and spiritual beliefs. So it's an example of faith, hope, and optimism, uh, illustrating religion and spirituality effects on personal health by increasing her resilience and maintaining allostasis. So you might remember we showed this slide from Oman's textbook, and on the left you've got religion and spirituality. This is the pathway that describes biologic plausibility. How is it that religion and spirituality work to improve physical health and longevity? Well, we have these mediators in the center of this graphic: health behaviors and disease detection and treatment influenced by religion and spirituality. Your social connections and support are influenced by religion and spirituality, as are mental health and character strengths. That all leads to some biologic functions. Immune system, the endocrine system, cardiovascular functions are all influenced by strong religious and spiritual beliefs, also referred to as host resistance. And I added in yellow here, host resistance is resilience under allostatic load. And so I went on to define what allostatic load is. And allostasis is defined as the body's physiologic adaptation to changes, that is, stressors. And these physiologic changes help you maintain homeostasis. Now, homeostasis is your physiologic equilibrium, but research has said, homeostasis is too limiting in its definition. Okay, we're not always homeostatic. Our blood pressure goes up at times of the fight or flight response, right? Your heart beats faster, so it's not always a static measure. So equilibrium does change. Allostasis is the body's adaptation to change. So allostasis is important, replaces homeostasis. Allostatic load is defined as the cumulative burden of this adaptation over time, and it causes wear and tear on the body. So if you have cumulative excess stress, this can give rise to imbalances in the neuroendocrine, immune, metabolic, and cardiovascular system functioning. Remember that category in that graphic, all influenced by religion and spirituality. And so, showing this slide again, um, if you have a response to stress, your body will adapt. Some stress can be energizing, toning to the system. Body system adjusts well to stressors without overtaxing resources. So you want to maintain allostasis. Now, if you have a stress reaction over time, if it's cumulative, that's called allostatic load. And the body systems achieve a kind of a balance, but everything is working too hard. Your body breaks down if you have increased allostatic load. It's wear and tear on the body. So the question about Heloise's story, getting back to the beginning, the question was what mechanism in the biologic pathway model that theorizes why religion and spirituality is linked to better health is best depicted in Heloise's story? Well, the answer is host resistance. If you go to that graphic that refers to that um, pathway, lowering homeostasis is incorrect because um, homeostasis is equilibrium. Well, you don't want to lower your equilibrium. The placebo effect has nothing to do with Heloise's story at all. Uh, I initially had just allostatic load as the answer to this question, but I thought, gee, that could be misleading. But I tried to make this question even more incorrect by saying increasing allostatic load, which clearly is incorrect. We don't want to increase the cumulative effect of wear and tear on the body. So host resistance was the correct answer. And then briefly, question about definitions. True false question. The modern non-traditional definition of spirituality is most useful for research, but not for clinical purposes. Okay. Again, you need to understand the distinction about the modern non-traditional definition and the, oops, going the wrong way, and the traditional definition. For research purposes, you need to have a clear variable that you can study. And the clearest and most distinctive definition of spirituality that has been mostly studied, it arises out of the traditional historical understanding that grounds spirituality in religion. So the research variable um, that is used for research, or that sounds redundant the way I said that, but uh, for research purposes, this definition is used. Spiritual is a subset of a deeply religious person whose way of life centers on and exemplifies the teaching of their faith. The modern non-traditional definition is more, I think I used a slide that showed New Age definitions of religion and spirituality. It describes a wide array of groups guided by common beliefs and rituals, such as astrology, witchcraft, invoking of spirits, spiritism, um, animistic rituals and practices related to the supernatural, but it's not the traditional definition grounded in one's religious beliefs where it's tied to a higher power. And I showed this graphic during one of the presentations. This is from Koenig's textbook from your readings. This is the traditional historical understanding of spirituality for research. So it shows spirituality as a subset within religion. And that's how just about all of the studies in the United States have defined spirituality for research, as opposed to the secular definition of spirituality, um, or a modern non-traditional understanding of spirituality, which is not appropriate for research, but it is useful in a clinical setting. In medical schools, for example, if patients really have very strong beliefs, spiritual beliefs about being one with the earth, that's important for a clinician to know about. But that's not what's been studied. That's not been the basis of the vast amount of evidence that shows religious and spiritual beliefs can affect health outcomes. So this is the modern non-traditional understanding of spirituality, where spirituality is very broadly defined, includes religious beliefs as well as secular humanistic beliefs. Um, Doug Oman, in his book, I think this appears in the very first chapter, The Elephant in the Room. He discusses the definitions of spirituality, and he says that studies of the health effects of spirituality, especially the modern non-religious forms of spirituality, are scarce and represent an important and greatly needed emerging subfield in the science of religion, spirituality, and health. So I hope you can appreciate that distinction. Now, if you want more information on the allostatic load, if you want to dig a little bit deeper here, there's a great um, review of this in Doug Oman's textbook in the chapter called Questions on Assessing the Evidence Linking Religion and Spirituality to Health. It's question number 12, pages 297 to 299. And then there was one question. Oh, by the way, I think we gave uh, partial credit or full credit to a couple of these questions I've gone over because we felt that the answers weren't entirely clear, especially the one I'm going to do. You know, everybody got credit for this question on secularization theory. These were the answers. The question is, which theory is one way to explain the following? And I won't read them all to you, but let me explain secularization theory. In Doug Oman's chapter, he referred to what the elephant in the room was. And it is the enormous amount of empirical evidence that links religious and spiritual factors to health, and very commonly to better health. And he described the field of public health as being intellectually blind and missing in action to this science. And one of the reasons he gave for that was the secularization theory, which was popular in the 60s and 70s when many um, members of schools of public health faculty received their training. And at that time, it was felt that science was going to render religious worldviews irrelevant and outmoded, causing them to fade into public life. So public health professionals were influenced by the secularization theory. This is one reason to explain why there's an elephant in the room. Public health officials really felt as if religion was going to be way on the back burner and have no role, be irrelevant in public life. And that has not been the case. So the answer to this question is C. Um, why the field of public health has not recognized a vast amount of research regarding religion, spirituality, and health. Um, the last question, uh, excuse me, the last possible answer, the decline in middle to older age adults who identify as being spiritual but not religious could indeed be explained by the secularization theory. That's why everybody got credit for that particular question. And I'm done, Professor.
Okay,
Be
thank you
happy to
so
take
much.
any questions if there are any. I'm going to stop sharing my screen and turn it back over to you, Professor.
Okay, sounds good. Students, did you have any questions about what Dr. Crucetti just mentioned, or?
I don't have any questions. I just wanted to thank you for clarifying some of that because some aspects like allostatic load I just got confused on, or I don't know, it was nice to have that refresher.
Oh, thank you. Appreciate that.
Yeah,
And,
thank you for clarifying a couple of the questions because I actually was confused. I went back and I switched answers right in the last minute. Last minute, I went back and switched answers because I was like really, but thank you.
You're welcome. As I said, it might not be a reflection of the student's ability to learn as it is the presenter's ability to present, Zoom and all. So I hope this review was helpful. Thanks.
and then along those same lines, just to bounce off what Dr. Crucetti just mentioned, I also identified a couple of other questions that were kind of loaded and that I noticed that you guys had slight difficulty with. So the first one actually gets into something that was mentioned in the Module 1 reading for the Johns Hopkins University Spirituality Alert. So it was a two-page document that you guys read earlier in the semester. And it actually had this quotation in it about the concept of spirituality is found in all cultures and societies. So the true answer would have been false, but I noticed that some of you guys did put true. In fact, most of you guys indicated true. So if you did indicate true, you didn't lose points necessarily, but the true answer would have been that the concept of spirituality is found in all cultures and societies. So this response that we gave here, which is some cultures and society, would have been false. But as I mentioned, we were able to use Blackboard to help us identify some of the questions that may have been a concern for you guys. And then, of course, Dr. Crucetti did a great job of tallying up the responses as well. He was able to do a manual accounting of sort of how you guys answered and juxtaposed that with the actual responses you guys had. So it was really helpful for us to look at that data and get an idea of the items that were tricky for you guys. And then one of the last questions on the exam was the one related to sort of connecting the built environment and also what we've talked about in this class. So essentially, if you indicated anything related to sort of churches or temples or, stakes or mosques, any kind of house of worship would have been the correct answer to the question regarding sort of this idea of how the built environment is considered to be a physical determinant of health. And so the presence of blank would have been some type of house of worship as being an aspect of the built environment that relates to religiosity and spirituality and also health outcomes. I think some of you guys indicated other answers related to sort of like walkability and sidewalks, but really what we meant was this idea of some type of house of worship. And it kind of actually reminded me a little bit about one of Oladameji's questions earlier in the semester about this idea of like some parts of New York City, you might have like multiple different houses of worship on one city block, for example. So that actually was a motivation for the question. But I thought it was a really great way to think about what we talked about also in terms of like social determinants of health and physical determinants of health. So in other words, if you didn't indicate these answers, you still got credit as well. So we did assign partial credit for some of these questions that we just realized were a little bit too loaded in the way that they were written. And then in the end, what we did was after everyone's grades were tallied, we decided to go ahead and add in an additional 2.5 points. So essentially, we went off of the sort of highest scores and the lowest scores and did sort of a calculation to determine that everyone would get that plus 2.50. So in your grade books, we actually did a manual override to make sure that we accounted for some of that. And, we're really excited otherwise to see that you guys did understand and absorb the most of the questions. So it was really good to see that for the most part, you guys have really been taking the readings to heart and also taking the lectures to heart. And that's one of the reasons why in Blackboard we make sure you guys have these recorded lectures available, but also you guys have access to the PowerPoints themselves if you click on the modules themselves in the course material section. So we were otherwise, quite impressed by your activity on the exam. And if anyone had any other questions about the midterm or the grading, just keep us posted by email. So did anyone have anything else to add about anything before we transition into module 7?
No, I just want to thank both of you for reviewing the questions too, because I think I definitely put true on this one also. And yeah, it's good to have the clarification. Thank you.
Yeah, absolutely. And any of you guys that have any concerns about the midterm grades or feel like it was a little too overwhelming, we do have that opportunity for you guys to get extra credit in terms of writing like a mini essay based on some type of sort of interaction with a religious or spiritual event that has some connection to health. But I'll talk about that a little bit later in the course today to talk about some opportunities for extra credit for anyone who may have felt like they wanted to sort of like improve upon the grade that they got for the midterm, especially considering that the midterm itself is 15% of the grade. You would be able to get back 2 to 3% of those grades towards your final grade through a potential extra credit exercise. So stay tuned about that later in the course today. So what I'll do is I'll go ahead and shift gears, and if I can get my Zoom toolbar to work correctly, I'm going to try to go ahead and let's see, update my screen. So what I wanted to do today was definitely switch gears into module 7 in the sense of us really thinking a little bit more about this idea of health promotion and also health education in terms of those being possible pathways for us as public health practitioners who are actually thinking about blending in certain social determinants of health into our practice. And so one of the things that I definitely wanted to just highlight was that, when we talk about some of these terms related to, health education, disease prevention, health promotion, in a lot of ways, sometimes these terms are used interchangeably. But I just wanted to highlight a few key definitions, just in terms of thinking about sort of the way that the World Health Organization and also the Joint Commission define some of these terms. So when we think about health education formally, it's the combination of any planned experiences that involve teaching others about sort of ways that they can learn more about their healthcare decisions or even improving things related to health literacy based on theories and also based on evidence. So we want to think about how health education can actually be used as a tool to empower not only individuals, but also groups and communities so that they're much better aware about the types of skills that they need to understand how to improve their own health outcomes by making more enhanced health decisions. And then when you think about health promotion, this is when we're thinking a little bit more in terms of almost like the ecological model in terms of sort of this idea of how can we think about combining influences from organizational mechanisms, educational mechanisms, the environment, political and regulatory mechanisms that may have some role on supporting the conditions among which we live that may be conducive to our health. So we want to think about what are those external and extrinsic influences that affect a person's health outcomes based on where he or she lives? And how does that affect not just the individual's health, but also the individuals who live in a specific community? So from that community approach, that's where we get this idea of health promotion that can be either from the individual level or the community level. And just keep in mind that when we talk about health education and health promotion, we're thinking about what types of things can we encourage another person to do to help improve their health behavior or their health attitudes. So you may remember earlier in the semester, I was talking about this idea of KAB, knowledge, attitudes, and belief. And that's an acronym that you'll see pretty often in the studies of socio-behavioral health. And so KAB, knowledge, attitudes, and belief, that essentially means that we're looking at what ways can we think about a person's baseline set of behaviors or beliefs in terms of what ways can we as the health practitioner or the community health specialist, what can we do to promote those voluntary changes that can affect the way someone sees not only their behaviors that may be disadvantageous to their overall mental and physical health, but also what types of voluntary changes in their, even in their lifestyle and their sort of attitudes and beliefs, what types of things can we influence that may help improve a person's quality of life. So think about how health education and health promotion are both influential on quality of life, but also how we're really hoping to spur these voluntary changes. And then just thinking about sort of a follow up to that, we really want to think of this in terms of being sort of a broad map of thinking about a bigger picture in terms of how health promotion and health education are sort of intertwined by all of these different mechanisms and influences. And so we definitely wouldn't want to dismiss the reality that sometimes our health behaviors and habits are actually shaped by things that are sort of a socio-political or something related to where we live in terms of our economic environment or our social environment. There may be things about the way that we consider health health behaviors or things that we do in our day-to-day lives that are influenced strictly by where we live or what types of people that we live around. So just remember that that's one challenge with sort of health education and health promotion is that there may be things that are difficult to address as someone who's working one-on-one with communities if you don't address the overall environment that that person or that community may be living in. And so when we think about sort of this idea of health promotion and health education, it falls under the umbrella of this idea of the acronym of HPDP. And I know when I was learning about this maybe 12 years ago when I was in my first year of the MPH program at Emory, some of my instructors called this essentially hippy dippy. So HPDP meant hippy dippy in the sense that it was really thinking about sort of what those factors are that take us through certain constructs of sort of that ecological approach. And so one reason they also called it hippy dippy was that a lot of these tenets of sort of health promotion and disease prevention, the theories themselves were starting to be developed along the timeline of the 60s and 70s when there genuinely was sort of like a hippie movement of people who were starting to become more interested in societal good and the common good. And so when you think about this idea of sort of like interpersonal, institutional, community, and public level factors, we really want to think about examples of how what we do sort of at the intrapersonal level may ultimately have a connection to the much broader societal picture. And also the picture of sort of how public health and also how advocacy affect human health outcomes through public health advocacy. So in this example, we're thinking about intrapersonal factors. So we're thinking about things that are sort of intrinsic to an individual, about maybe a person's self-confidence may have an effect on his or her ability to understand the importance of taking care of their mental health or their physical health. So that's an example of how an intrapersonal factor could be something that you may want to encourage your client to think a little bit more about it, seeking out counseling to improve that. You can also think about things related to obesity prevention, for example. What ways can you educate people who are part of a community to learn more about strategies related to nutrition and physical activity? If you think about interpersonal, this is how we engage with each other as a group. So we want to think about, let's say, for example, in this specific class, this Zoom classroom, all of you who are students, you guys interact on an interpersonal level when we have some of our activities where you guys go around and give your perspectives on some of the case studies we've done so far. So this interpersonal level is thinking about how is it that individuals communicate with each other in a way that may promote health. And so one example of this would be if you had sort of peer engagement and a sense of community among a specific group of people. This is how you have things like community walking groups where everyone's sort of supporting each other to have more increased physical activity. You also have sort of this idea of having sort of peer groups, even in terms of supporting each other through a chronic illness. So I remember when I was still working in the oncology environment at our specific cancer institute, the social work department sponsored various types of support groups so that peers of people who had similar types of cancers. We had a breast cancer support group. We had one for people with lymphoma, one for people with leukemias, and also there was a support group option for people who were the actual caregivers and the family members. So this idea of different types of chronic disease context, it's very often that you'll see the interpersonal level used to promote health promotion in the sense of you thinking about how someone who's just like you, whether it's your neighbor, someone who has the same disease outcome as you, someone who may also be supporting or taking care of a family member, how is it that people who are like you can be your form of support? And it's not too different from what you students would do in the sense of having a group of students to get together to get ready for an exam or get ready for a test. It's that idea of thinking about how your fellow man or woman can actually help you in terms of promoting some type of goal for health. Then we think about the institutional level. This is when we're thinking a little bit more about the places that we sort of work and the places that we go to school. So the institutional level is an important avenue for thinking about health promotion and disease prevention, specifically because we're thinking about what ways in which we can have a supportive environment for improving our health. So does the place that we work or the place that we go to school or even the place that we live, do we live in a community or a workplace, or are we part of a school environment that has supportive options in terms of healthy eating or ability to access physical activity? One thing that comes to mind with the School of Public Health was I remember about maybe 4 years ago, there was an initiative by, I believe it was one of the professors in the health policy department to improve the types of vending machines that we have over in the student lounge area that's on the first floor of the George Education Center. So that involved them doing sort of a canvas of the types of snacks that were available in that vending machine. And they did a complete overhaul sometime in 2016. So that way the machine itself had a lot more sustainable and ecologically and nutritionally friendly foods available in that vending machine. So that was just one example of an institutional example of how even our School of Public Health work towards health promotion among our student body and our faculty body to make sure that if you're hungry over at the George Education Center and you don't necessarily want to make the long walk over to the cafe in the other part of the Rensselaer campus, you could at least get something that was relatively affordable and relatively healthy right there in our main classroom building. Now, when we think about the community level, this is when we think a little bit more about this idea of how can we actually engage communities as a whole. So we want to think about things such as, let's say, a community health fair. How can we empower communities as a whole to be more aware of how they can absorb health messages in a way that actually may alter their own health behaviors and health beliefs? So we want to think about how we can educate communities in terms of broadly disseminating information. And this is where we really see that the power of social media can be extremely helpful. So social marketing campaigns and also social media related campaigns can be extremely important in terms of print media and also digital media that can be sort of helpful in educating others about public service announcements and also tips and also resources that may be present in the community that may be supportive of health. So one thing I can think about here in the Greater Capital District area is that when you think about food insecurity, a number of the different CDTA bus stops actually have billboards that actually give out information about the Albany County and the Schenectady County resources that are available to get free and low cost food, whether it may be food pantries, but also it can also inform people about ways that they can be a part of the Capital District Veggie Mobiles that I believe are sponsored by either MVP and or CDPHP insurance. And so these are just examples of things that are ways to have sort of public service announcements and health communications in a way that help curb food insecurity here in this area, because it helps promote that idea among people who use public transit here in the Capital District. And then when we go into the public sort of arena, this is when we think about sort of the broader societal good. So we want to think about what is it about the policies and also the regulation that may sort of be disingenuous or maybe something that it goes against the idea of promoting public health. So we want to think about, is there legislation in place that sort of doesn't support healthy policies or doesn't explicitly mention a way for there to be policy surrounding built environment or nutrition or physical activity? Is there a situation where the communities at risk simply don't have programs in place that are funded and consistently available to address certain health issues in that community? So let's say it was a situation of, let's say it was a rise in cases related to a certain level of waterborne illness in a specific community. In what ways are there going to be some ways for there to be programs to educate people about safe drinking water and also ways to inform themselves about being careful about hygiene or cleanliness? Is there anything specific related to reducing whatever infectious disease or waterborne illness may be present in a community by simply just funding programs to help promote health promotion, to help others understand a little bit more about ways that they can protect themselves at home and also improve the ways that they eat or drink things in a safe manner to reduce contamination and contagion? So we want to think about, when we talk about a lot of these different interventions in the health education and health behavior context, we really want to think about the role of evidence-based theory. So, we have a number of different theories that are very instrumental in shaping a lot of the issues related to behavior change. And so, some of these you guys may be familiar with from other classes. We have, things like the theory of innovation, things like community readiness model. There's also the precaution and adoption process model, the trans-theoretical model of change, the theory of planned behavior. Also, the social network theory and the social cognitive theory are very popular. In addition to social capital and also the health belief model. And just think about how these different theories are really sort of most useful when they're used in specific contexts related to what we just talked about in terms of those different gradations of intrapersonal, interpersonal, and also community level. So just to go through a couple of examples of that, one example would be the trans-theoretical model. This one is very, very popular when it comes to thinking about how you can consider helping a person or helping a client that you may have in terms of educating them about sort of ways to improve upon some type of health behavior that is something that is being disadvantaged to their health outcomes. So with the example of, let's say, physical activity, you think about this idea of pre-contemplation. A person may be very interested in increasing the level and the amount of exercise that he or she does, and they may also be aware of the advantages of being physically active and the disadvantages of not being physically active. So you want to think about, is a person actually in that pre-contemplation mode? That's different than someone who's already in the contemplation mode, who actually is starting to think about how they can actually identify barriers in their own life that are actually being something that was curbing or discouraging them from physical activity. So one key difference between pre-contemplation and contemplation is that, pre-contemplation, a person doesn't necessarily have a plan in place, and they may not have necessarily even sought out help for whatever the issue is. But with contemplation, the person's getting that much closer to thinking about ways that he or she can actually think about encouraging their own self-empowerment. When you think about the preparation mode, this is when a person starts to really think about what resources she or he may have available to them. So they start to think about ways that they can use peer support systems, for example. Or is it possible that there's some kind of resource available to them at their school or work, or even something like a public park that can help them in the example of physical activity? So a person in the preparation mode has moved on from the pre-contemplation and the contemplation mode because they're actively thinking about viable changes that they can start making and goal setting that they can start thinking of. And when you think about the action mode, this is when a person has actually started to get into the goals and they really have started to think about what barriers have they had historically that have maybe made them not likely to necessarily uptake that healthy behavior. So this is when you think a little bit more about the action level. This is someone who most likely at this point may have actually sought out some type of help. So this is someone who may have, for example, sought out a personal trainer, or this is someone who may have decided to sign up for a session at a public park where you have to sort of sometimes sign up for a specific slot to do team-related exercise. If it's, let's say, reserving a slot for a group of friends on the tennis court, or reserving a specific group of time to play soccer with your friends, and if it's a situation where you have to sign up for an hour or two at a time, this is a situation where the person is being active in their thinking to actually have that confidence to maintain the change by taking some action. And when you think about the maintenance phase, that's when you think sort of from a longer term, you really start thinking about, okay, has this person actually done this type of action for a period of, let's say, 3 to 6 months? And so when you think about this trans theoretical model, there's actually more of a time window that goes into it. So pre-contemplation could very well be like 3 or 4 months before the actual action occurs. Contemplation also could be something that's like, let's say, a month or two before. Preparation could be those weeks leading up to the intended action. And then the action itself is when the person kickstarts the activity. Whereas the maintenance is really when that person has already demonstrated that he or she has actually made the commitment to make whatever change it is, and that he or she is also actively using whatever peer or social support is available to them. So maintenance is something that's always measured in terms of a time duration after action, which usually can take months and sometimes years. Now, when you think a little bit more about another very common health behavior change theory, one of them would definitely be the health belief model. And this is when we think about some of the intrinsic beliefs that a person may have that may be dissuading the person from actually taking some type of action to actually make the health behavior change. So this is when we think about things like perceived susceptibility, perceived severity, and also similarly, what are the perceived barriers that a person may have in terms of things that they think may be a cause for a concern? And also, what types of benefits does that person envision in terms of actually making a change? So, with this example of diabetes management, one of the things that stands out with perceived susceptibility in this example would be just simply thinking about how you can educate an individual about whether or not their weight or their BMI is a risk factor for prediabetes or for diabetes. So this is actually something that's very common in health education, where you sort of do a baseline assessment, where you actually sort of understand a little bit more about what does the person know already about what exactly would be their perceived susceptibility to disease. And I remember when I used to work in the endocrinology clinic, we had a lot of patients who were at that pre-diabetic level. And one of the things we made sure that they understood more about was the different gradations between, sort of overweight versus obese BMI. And even in some cases, the differences with normal versus underweight BMI, and what those classifications are in case that was an issue for someone in their family or they themselves, in terms of understanding whether or not their weight itself was a proxy risk factor for diabetes. When you think about perceived severity, this is when you think a little bit more about this idea of thinking about sort of what could be the potential effects of a person not doing something. So what does this person understand in terms of the severity of not making the change? So you really want to think a little bit more about, if this person got sick, what exactly would be the disadvantages or the complications to that person's lifestyle or quality of life. So perceived severity is important to assess if possible, because this is an opportunity for you to actually discuss this with your client to make sure that they understand the importance of maintaining or preventing the illness, in terms of understanding how not doing so could actually be disadvantage to their overall health related quality of life. When you think about perceived barriers, this is when you think a little bit more about, what is it that a person thinks would actually be a deterrent to making the change? Is it possible that the person lives in a neighborhood, for example, where they don't necessarily have access to mobile food clinics, or they live in a neighborhood that has a lot of convenience stores and bodegas that may not necessarily have a high uptake or availability of fruits and vegetables. One of the things that's really great about New York City's health department is that they've made a lot of efforts in the last 5 years to actually fund incentive programs for a lot of the bodega owners and convenience store owners to make sure that there's a certain percentage of fresh fruits and vegetables that are part of the stock at those particular stores. And the health department actually provides grants and incentives to participating stores. And so that's an example of how, a person may have had a lack of access to healthy foods, for example, and that may have been a barrier. But it's possible that it may be that that barrier is something that's not even an issue, because it could be that where they live actually does have a dearth of or doesn't have dearth of exercise facilities or healthy foods, but that person just may not know about it. So when you're with a client and you're talking about perceived barriers, this is an opportunity for you to help educate them a little bit more about what may be present as a resource in their community that he or she may not even be aware of. And then when you think a little bit more about, perceived benefits, this is when you talk a little bit more about really how a reduction in disease occurrence can actually occur if that person makes the changes that's required to improve their health. So with this example about sort of diabetes prevention and diabetes maintenance, you're thinking about how you can educate your client about how there's a benefit in terms of increasing their duration of physical activity. If they're doing, let's say, less than 150 minutes, how can you encourage that person to meet the weekly goal of 150 minutes to 300 minutes of exercise or physical activity? In what ways can you educate the individual about maintaining a healthy diet, and also ensuring that in some cases a person may be helpful for them to keep a food diary or some type of food journal? So this is something where you have a chance to sort of educate people about the benefit of making those changes so that they can reduce their potential risk for the disease. And so in this case, you can think about how you can speak with your clients about these perceived benefits, and also juxtapose that within the context of helping address any concerns related to susceptibility, severity, or those barriers. And so these are just, some of the common theories that you see in health education. And for those of us who have been health education specialists, these are some of the most common that are really the most advantageous in the sense of being applicable to a lot of different types of client situations, and also a lot of different health outcome situations and contexts. So I'll just summarize by also mentioning that another one that's also helpful is the theory of planned behavior. And what's nice about that one is that, it really gets into this idea of behavioral intention. So you want to think about a little bit more about, sort of, did this person already have some type of baseline behavioral control already? Is it someone, for example, who's already sort of thought a little bit more about, let's say, healthy eating in the context of, let's say, thinking about sample size or serving size? Is it possible that the client that you're talking with, who may be at risk for some type of sort of obesity or some type of diabetes or some food malnutrition related concern, has this person already thought about ways that he or she can improve the ways that they already eat certain foods? Are they thinking about the healthy plate model already? Are they already adding a lot of color in terms of different types of vegetables to their plate already? So you want to know a little bit more about what types of levels of behavioral control that person may have already had. And you also want to think a little bit more about what level of intention had that person already had. And then if there's an issue where their intention doesn't necessarily equate to their subsequent behavior, what can you do as the health promotion specialist or the health educator to really help bridge that gap between what the person's perception of behavioral control has been, and also how they can really actualize that in terms of making that change? So the TPB, the theory of planned behavior, is another common one that you'll see in a lot of the health literature. And what's exciting is that, I noticed in reading through the two Oman chapters for this week that even though it wasn't explicitly indicated, some of those interventions that were summarized actually involved a theory-driven intervention. So it's very empowering to see that you do see that some levels of theory are actually um, explicitly or sort of implicitly being injected into some of these interventions. And so when we think a little bit more about, the idea of actually mapping an intervention, this is when we really start to think about the CDC framework as being something that could be helpful to you in the future. So you really want to think a little bit more about, your first step is this idea of needs assessment, also known as community needs assessment. And you really want to think a little bit about how can you understand a little bit more about your population within the context of what are the resources available in that community, what types of epidemiological profiles are already present in that community, what types of social and demographic factors are at play. You really want to think a little bit more about this needs assessment as being your first step. You also want to think a little bit more about the idea of sort of the matrices of change. So this is when you start to identify what would change as a result of the intervention and who would be the person that would change in that community. So you want to think a little bit more about this idea of the stages of change and the matrices of change in terms of understanding more about who within your community or who within your population is the sort of focus of your specific intervention. It could be in your needs assessment that you identified that there's a specific subset of people who are more likely to take on certain behaviors or certain types of social characteristics that may be disadvantageous to health. So those would be the members of the community that you would think about in terms of thinking about who and what would need to change as a subset of what you've identified in your needs assessment. Your third step would be thinking about this idea of what are those theory-based methodologies and practical strategies that can help you in terms of theory-based intervention planning. So you want to think about exactly which of those theories could be helpful. I only highlighted three, but in reality, it's about maybe 12 of them that you could actually use at your disposal. And what I'll do after the class is I'll make sure that I upload to Blackboard a summary document that not only goes into the three theories that I talked about, but also the other 7 or 8 that are commonly used that may be helpful in terms of any theory-based intervention work that you guys do in the future. The fourth idea would be to think about program development in terms of thinking specifically about what types of materials might you need and also what types of intervention logistics do you need. So you start to think a little bit more about, well, what types of staffing would I need for this intervention? Who would be my stakeholders? Exactly what type of time horizon would be necessary? You start to really sketch out your program and develop it at that fourth step. Whereas in the fifth step, this is when you start to think a little bit more about, does logic modeling help me? Does a logic model that helps me develop matrices to focus on specifically what will be done and by whom, would that be something that could actually be helpful in terms of thinking about how this intervention will be widely adopted and widely implemented? So for any of you guys who have taken any sort of evaluation courses, you may have already gotten an introduction to logic modeling. But if you haven't, I'll make sure to upload to Blackboard a link to the University of Wisconsin course. It's a really helpful introduction to logic models for any of you guys who don't have a chance to take the program evaluation course that's offered here at the School of Public Health. And it's a really good way for you guys to learn a little bit more about thinking about how to develop those matrices to really map out your plan for thinking about adoption of your program and who exactly would be your intended implementers. And then finally, related to that, you're thinking a little bit more about evaluation planning in terms of actually doing that process and outcome evaluation. And so you want to know a little bit more about whether or not the intervention that you planned is implemented the way that you intended, but you also want to know about whether or not there's been short-term and long-term changes that have actually resulted that may have influenced the epidemiological profile of that community. So this is when you really start to think about sort of the long-term impact of what you've done, but also the short-term impact. And for anyone who's familiar with logic modeling, one way that this is mapped out is you think about sort of your short-term outcomes, which are literally like the first few months of implementation. Your longer-term outcomes are usually those that happen within the first year. But then what's called the impact outcome is usually things that are more sort of long-term in the sense of being maybe 2 or 3 years after the intervention is complete, because you really want to think about what that long-term impact has been. So this is where evaluation planning can be really helpful to learn more about whether or not what you've planned in terms of your theory-based intervention, did it really work to actually have a positive outcome in changing the epidemiological statistics or any sort of baseline demographic issues that were deterrents to health. This is a good way for you to think about how that actually would operate in your community in terms of doing that outcome evaluation. And so when we think a little bit more about what we learned in the Oman textbook this week, the first chapter that you guys were assigned, I believe that was the chapter that was entitled Public Health Education, Promotion, and Intervention. What I thought was interesting about that chapter was, he really reiterated this idea of faith-based versus faith-placed. And so what was important to sort of highlight about that was that he talked a little bit more about the distinction in terms of the idea of faith-based being something that has some type of religiosity or spiritual component in the actual intervention versus something that is faith-placed being something that you would expect to see happening in a faith-based organization or something occurring in a house of worship setting. So this is when we think a little bit more about that blending of a secular intervention within an actual religious setting of some sort. And so what I think is really, important to highlight is, the example on I guess it would be my right, is sort of a community health fair that occurred at a Episcopal church. I believe it's St. Stephen's Episcopal Church in the Midwest. And this is an example of a community health fair that they did within the community center that's adjacent to the actual church. And, it involved sort of like activities for children. It had sort of pamphlets and informational material for the adults, and also kid-friendly activities to help children understand more about oral health, and also so that they could understand a little bit more about ways to think about mental health. All of these were different booths that occurred at this specific health fair. And community health fairs are really ripe examples for thinking about how you can actually have an intervention that's a collaboration between members of the clergy who support the idea of having such an event at their house of worship, but also they can be really useful in terms of helping promote the event, in terms of actually sort of promoting the event with their different parishioners and members of their house of worship, in case it's a situation where you have the community health fair occurring, let's say on the same block as the house of worship, and you really need to make sure you have help with recruitment and engagement from your key stakeholder, which would be some of those faith-based organizations that are present in that neighborhood. So faith-placed in terms of thinking about how those houses of worship can be settings is really important when we think about primary and secondary prevention, because, we've talked a little bit about the differences between primary, secondary, and tertiary prevention in the past. And so you want to think about, before a person gets diagnosed with an illness or before it gets too severe, which would be tertiary prevention, what is it that we can do at the primary and secondary levels? And it's really important to think about how churches and other houses of worship have been very helpful in terms of being those faith-placed interventions. And even going beyond the community health fairs, we've seen examples where you've had settings where there have been cervical cancer screening events, mammography events held at churches, and also thinking about how sometimes you've actually even had diabetes education and sort of cancer prevention workshops and different types of events where a health educator may actually come to the site of that faith-based organization or house of worship to actually educate the members of that congregation about certain behaviors and activities that can be beneficial to health. So these are all things that I think are really good examples of faith placed. And I think the Oman textbook chapter really highlighted the importance of that. And then he juxtaposed in that chapter the idea of how health ministries and healthcare programs sometimes can actually be intrinsically built into faith-based interventions. So this is when you see religious and spiritual components being embedded into an intervention that may not necessarily occur at a house of worship per se. So what I thought stood out the most from the chapters was, he talked a little bit about the rise of workplace sponsored settings. And you're thinking a little bit more about ways in which a workplace or an employee assistance program may have mechanisms in place that actually involve a little bit more about helping employees improve their work-life balance. And so what I think is so important about thinking about that is that in the last maybe 5 or 10 years, there's been a significant spike in interest by corporations and also other types of employers to really fund these employee assistance programs. And so there's been a important increase in terms of helping employees understand the importance of mindfulness and also the importance of any types of strategies to improve their ability to sort of have that mind, body, spirit balance. And so, one example would definitely be thinking about meditation clinics and also yoga related and Pilates related courses or, sort of opportunities for the employees to take Tai Chi as a group, things that are essentially funded by the employer, but have some of those tenets of religious or spiritual components within them. And so, I do think that that's something to look out for in your own future workplaces, to look out for those free or low cost opportunities for having some type of faith based ability to have that balance as an employee and thinking about how that can actually be advantageous in terms of how it actually helps those employees feel a little bit more at one with balancing their workload with their own personal health behaviors and health promotion. So I just thought that was really, important to highlight. And I think that at this point, if no one has any questions about the book chapters, I'd like for us to take a break. So did anyone have any questions about anything that was addressed in the Oman textbook that you'd like to ask us? And if you do, feel free to unmute yourself. Okay, well, if that's the case, what I'll do is I'll have us go to a break for about 10 minutes. If everyone could rejoin the group around 4:23 in 10 minutes, we'll jump into the second part of the lecture. So I'll see you guys at 4:23. Okay, everyone, we'll get started again now. So what I hope to do in this second part of the lecture today was really to think a little bit more about what we can learn from some of the various interventions that were mentioned in the Oman textbook. And what I thought was a common theme in terms of some of the examples that he showed in the book chapter, and also the other chapter that did sort of a broader survey of how health promotion activities actually occurred, we really want to think about in what ways were those interventions tailored in a way that may have taken into account the idea of religion as a function of cultural competence. And so I really was thinking that this would be a great way for us to talk a little bit more about some of the key terms and the studies of cultural competence in healthcare. And in some ways, how sometimes the terminology of cultural competence is misconstrued with other important definitions such as humility and also awareness. And so, I'm really hoping that in this second part of the class, we'll get to think a little bit more about this idea of religio-cultural competence. And so essentially, you think about what it is that makes up a person's culture, so to speak. And so, of course, a lot of the traditional definitions relate to sort of like where we live, what our racial or ethnic background may have been, what history there have been in terms of immigration or migration in our families. We also think a little bit more about things specific to our individual profiles, like our gender, and also we think about our age. So these are important factors that we see, traditionally in a lot of the public health interventions in terms of there being specifically tailored interventions for a certain age group or a certain ethnic group or even a certain community of residents, for example, that may be defined by some type of shared socioeconomic variables. But what's interesting is that, when we think about the idea of religion and spirituality, those are aspects of an individual's culture that can really have an effect on that person's worldview. And in a lot of ways, a person's religious or spiritual beliefs may also be influenced by historical events that have occurred in that person's family narrative. And they also could have been the result of some type of generational influences as well. And so, it seems to be similar to what we talked about earlier in the semester related to religion being this sort of underappreciated social determinant of health. Religion and spirituality are also important factors that are underappreciated in a sense when we talk about culture, because it's very important to think about how whatever baseline religious or spiritual beliefs we may have grown up with or may not have grown up with, how that may affect us in terms of our behaviors and also our belief systems. It's very common for people to may be grow up in a certain religion or even grow up in a certain spiritual sort of mindset, and that may shift as that person becomes an adult. Or you may have a situation where a person may have been raised in a family that was relatively secular, that may have had some type of agnostic or atheist beliefs. And so that too is important to consider when we're thinking about designing appropriate interventions that are tailored to our specific clients and our communities of interest. So we definitely have to think about how culture is very much a very nuanced term that has many different levels and gradations. So what I think was interesting about, cultural competence discussions is that in a lot of ways we talk about cultural competence being sort of conflated in some ways with cultural sensitivity and cultural humility and also cultural respect. So the true definition of cultural sensitivity is this idea of thinking about how we can communicate respect for culturally different patients or clients. So this is when we think a little bit more about what is the importance of assessing a person's cultural values, whether it's for that patient or their family members, by using cultural sensitivity. So we want to think about this idea of this iceberg. So on the surface, you see a person's language or you hear a person's language. You may understand from them what types of things they like to eat or what types of clothing they may wear. You may see things related to their physical attributes or something that's more visible that you can understand about a person. But it's until you really scratch the surface of that person and think about sort of the hidden layers of that person that aren't necessarily visible to the human eye or to the naked eye. And this is when you think of this iceberg effect. So you're thinking about what is beneath that surface. So it's important to think about how an individual may have their social norms or their cultural norms really be shaped by some types of belief systems or attitudes or values that are important that may have been shaped in fact by something that's related to the way that that person grew up or the community that that person's lived in. And so you want to think about how you should tailor your intervention in terms of the appropriate communication styles that are important to take into account when we think about having a culturally sensitive intervention. So it's important, when you talk about cultural sensitivity, to at least acknowledge that there's some type of difference that may exist between you and that client or you and that community. So cultural competence is a much sort of more advanced level of actually being competent with working with different types of culture. But cultural sensitivity is just simply saying that you have a sensitivity to being respectful about the idea that there may be people who you're working with in terms of your patients or your clients who simply have a different belief system that they're believe in or different cultural norms that they actually practice. And so just acknowledging that difference between yourself and your end user is very important. Similarly, when we think about this idea of cultural competence, this is when you're thinking about how can you structure your questions. To really think about sort of how you can ask questions of your clients in a way that promotes health behaviors that are actually going to be positive, but you're doing it in a culturally sensitive way. So you want to make sure that if you're a clinician or a public health practitioner, that you're actually considering what exactly are those cultural differences, not just amongst yourself and that patients, but even among your patient population or your clientele load as a whole. So you want to understand that, let's say you're a public health specialist who's designed a cervical cancer intervention program. You want to know that the women who may be taking part of this program come from 4 or 5 different ethnicities or ethnic groups. So let's say you know that your cultural categories would be a subset of women who may be white, they may be Caucasian, I'm sorry, they may be white, they may be Black, they may have had Asian ancestry, they may have had some type of Latino or Latinx ancestry. And because of that, you want to know a little bit more about what exactly is the cultural difference among those patients. One really good example of this is when you think about people who study Asian American populations, you think a little bit more about how there's a distinction between those who have East Asian ancestry and those who have South Asian ancestry. There's a lot of difference in terms of the cultural norms and cultural beliefs when you're talking about South Asian American versus those who have an East Asian descent. So it's really important, for example, in those cases to think about what exactly could you as a provider think about in terms of the differences between the people who would be the end users of your specific intervention or your health education. So what exactly is it about those differences amongst your intended end user, whether they be patients or people who participate in your health promotion program? So you want to think a little bit more about this idea of the difference between biases and also stereotypes. In a lot of ways, all of us have some type of bias, whether it's implicit or explicitly indicated in terms of people who maybe don't look like us or people who we didn't grow up around. So it's just really important to acknowledge that a bias itself is something that can be sort of learned about. You can do sort of a self-reflection to learn about any sort of bias that may be present in the way that you grew up and the way that you consider your communications with people now. But that's different than a stereotype, which is actually being taking it a step further in terms of actually applying your level of implicit or explicit bias in a way that can be a negative stereotype towards a certain group of people. And so what's really good to know is that a lot of medical nursing schools and even public health programs have started to have more training series available to students and staff to really help them understand more about the power of appreciating what any implicit and explicit biases are so that it can help shape a better understanding of working with our clients and our patients in a culturally sensitive manner that promotes cultural competence. So just think about it in terms of cultural sensitivity and culturally sensitive thinking is what actually triggers cultural competence in the end. So we want to talk a little bit more about a related construct, which is cultural humility. We want to think about what exactly is it in terms of identifying our own biases within ourselves that may actually need to be recognized so that we have that ability to be oriented in another person who's different from ourselves. So cultural humility is actually somewhat different from cultural competence in the sense that you're really thinking about what exactly is it that is an aspect of your own identity that you want to think about in terms of how you can consider your interactions with other people. So you want to think about in what ways can you communicate with a person in an humble way that allows that other person to understand and receive your communications in a respectful and humble manner. So you want to make sure that you prioritize the ultimate health goals or ultimate health behaviors of your client or your patient in a way that is indicative of some type of humility on your part as the person who's providing them with that education or with that consultation. And so when you think about cultural humility a little bit more broadly, it's really thinking about this idea of self-reflection. And you want to think about what your own baseline assumptions and beliefs may be about a specific type of people or about your own sort of belief systems that may be things that are different from the patient's belief system. So you want to think a little bit more about our own intrinsic understanding so that we can unfold ways in which we can better communicate to that end user, patient, or client to help them become more aware about a specific health issue. So cultural immersion can be very important in terms of making sure that whenever you're interacting with a client or a patient, whether it's at the community health clinic or whether it's in a hospital, you really want to understand a little bit more about that cross-cultural nature of being immersed in communications with that person. And, it may be helpful to share examples of interactions you've had with people who are of a similar social or demographic context as that person, but you do have to be careful not to generalize either. So just because you may have had experience working in, let's say, a prostate cancer prevention program with men who, let's say they're older men of color who may be Latino or African American, just because you work with those men in a prostate cancer prevention context doesn't necessarily mean that you're always going to be able to relate those same belief systems that your clients helped you understand more in another context. So it'll be important to think about, not generalizing about a specific group of people just because you've had success or some type of familiarity or comfort with working with people of that same specific group in the past. So that's where it always is important to have that self-questioning and self-examination of your own beliefs to ensure that you're constantly doing the work in terms of making sure that you're thinking about how you can cultivate a reflective and humble mind. And so what I thought was also important about this subset of cultural humility is really thinking about the idea of active listening versus passive listening. Unfortunately, in a lot of situations, whether it's healthcare or sometimes when we interact with patients in public health, we have a very limited time window that we can sort of speak with them. And the problem with that is that it ends up being where you're thinking about, okay, I only have 3 hours at this community health fair to interact with as many people as possible, or I'm a clinician and I only have, 10 minutes or 15 minutes with that person. And this is something I'm sure Dr. Crucetti can definitely speak to as a clinical provider, but active listening is very important to sort of think about what ways you can learn more about your patient's life story or narrative in a way that avoids you jumping to conclusions, but also giving you time to absorb enough sufficient relevant information about that person's narrative that can help shape what you're doing in terms of helping improve that person's health. And you want to think a little bit more about how cultural humility is not necessarily something that you do as a one-time exercise. It really is something you should really commit yourself to as sort of a lifelong career process. So throughout your career, you really want to be actively involved in thinking about ways in which you can improve your relationship with others of different cultures and other backgrounds, and also thinking about your relationship with yourself in terms of how you can improve or deter yourself even from having explicit and implicit bias affect your work with your patients and your clients. So it's definitely something you need to commit to in terms of thinking about how public health is really a proxy for thinking about the social good and the common good. So in a lot of ways, all of us who are in this Zoom classroom right now have already kind of committed to this by sort of thinking about how public health allows us to think about populations at risk and communities at risk. So we've already done some of the work already by dedicating ourselves to a field like public health that actually is thinking about these ideas of cultural sensitivity and cultural humility. So in a lot of ways, I would say we're already doing some of that work just by taking classes such as this one. And so what I wanted to do now, before we, shift to the latter part of the class, was I wanted us to actually sort of have a sort of video clip that we will watch. It will be about 10 minutes. And I'm also going to share it with you in the chat in the event of any kind of, sound glitches or media glitches. But it's a really important example of a group of women who are having a patient encounter at a clinic. And I think you guys will find that this activity is really a good way for you guys to think a little bit more about religion as a way of having cultural competence. And there are some papers that I'll actually link into Blackboard that specifically talk about the idea of what's called religio-cultural competence, which allows us to think more about this idea of religion as a proxy for thinking about culturally competent communication. So what I'm going to do now is I'm going to share my screen and also my computer sound with you guys. I'll play a clip, but first, before I do that, let me also share it into the chat so you guys have a way to watch it if necessary. But we're going to watch it as a group together as well. And so let's see, I'm going to improve my computer sound so you guys can hear it, and you guys can let me know if you hear it okay. But it's a really good way for us to think about some of these ideas of religion and spirituality. So I'm going to play it now.
We were kids who were placed in the system and were expected to function like every other normal kid in the United States. But in reality, we were normal kids. We didn't have any physical deformity or anything visible, but we had scars that were invisible. A lot of them did not make it. Some of them died because of they joined a gang. Some didn't make it through depression. I think, overcome it all. When I look, I see, like a kid. We had the war. Kids are, to be seen, not to be heard from. So nobody was comforting us. there to attend your emotions and say, you went through war, you watch people blown into parts, we lost our belonging, our home, our whole identity. But this is why nobody ever said that. So it just left us alone. And then we came here, and here in the United States, people are like, oh, here's your physiology needs in your home and everything. But you're forced so much to just be your own self in a short period of time, and all you hear is, why are you not assimilating, why are you not becoming? But that time is when I felt like when we were our worst self, it's when for the first time, we were no longer, as a kid, I was no longer watching after my sibling. I was no longer worried about water or food, or if my mother would get to a medical facility every time she had a miscarriage. So after all that, responsibility was no longer on my shoulders. I was forced to face me. My highest point will be who I am today. Yeah. Now that I am an interpreter myself, working in Maine, I find that a lot of people would put me under the category of an expert. And I used to say that, what qualifies me to be an expert? I'm just a Somali person. I learned what Somalia is and how their government was working, whatever. Like any other American person, I Google a lot. Even though we have one culture, one language, whatever, we also have different cultures individually. Every household have their own little culture, that the way they raise their kids, the way they go about the Islamic religion is different than the next door. So not to assume that we all dress alike, eat alike, talk alike, it's not the case,
This is Najma, a 20-year-old woman from Somalia. Last year, Najma and her husband were set to be resettled by the United Nations to Lewiston, Maine. 2 weeks before their departure, Najma's husband died of a respiratory infection he contracted in the refugee camp. A month later, now in Lewiston, Najma discovered she was pregnant. Najma's neighbor urged her to make an appointment to see a doctor. She said it was very important for the health of Najma and her baby. In Somalia, people only see a doctor if they feel sick, but trusting her new friend, Najma made an appointment. The receptionist told her to come at 2 o'clock on Tuesday. She had errands to run till 5, but in Somalia, patients wait to be seen, sometimes in the order they arrive, sometimes at the discretion of the doctor, sometimes for hours. So coming later would just mean someone else would get the chance to see the doctor first. The errands took a little longer than expected, so Najma arrived at 5:30 and was flustered to find the clinic had closed. When Najma called the next day, the receptionist said that they closed at 4, as always, and that Najma needed to show up the next day at 10 a.m., or else there'd be no time for her for a month. This wasn't anything like the system she was used to. Najma felt terrible being spoken to like this. She hadn't meant to convey any disrespect to the receptionist, and she was frustrated because she had no idea why she, a healthy woman, was going to the hospital anyway. The next morning, Najma took a little longer than normal getting out of bed. She'd been sleepy in the mornings lately, but she was only 15 minutes late, so she figured she was close enough. The receptionist did not agree. She rebuked Najma for her selfishness and lack of respect for others. She then handed Najma a clipboard of forms to fill out and sign. None of this made any sense. In Somalia, there are no set appointment times. Doctors take as long as they need with each patient and then call the next in line. There aren't any forms to sign because records are seldom kept. Najma wondered if the forms meant she was in trouble. She could speak and read simple English, and the forms had many questions about her family and her past. Some questions were very personal. Were these questions for the police? Would they be used against her? She wished her husband were here to handle these things. She felt like there was no one to help her. She did as she was told and filled out the forms, hoping not to get into any more trouble. Najma's name was called by a cheerful woman who introduced herself as a nurse. She didn't know that word. The nurse did things Najma expected the doctor to do, taking her blood pressure and pulse. She asked more personal questions. Then she left, saying the doctor would be along. Najma waited 10 minutes for the doctor. Why had the receptionist been so angry about Najma not arriving on time if she was just going to be kept waiting? Why not just come get her when they were ready? In Somalia, the powerful often kept subordinates waiting. She guessed that's what was happening here. The doctor finally came. Najma was relieved. The doctor looked at the computer and then examined her a little. She said Najma showed signs of anemia. She told her she was ordering a blood draw for a full CBC and a prenatal panel. Najma didn't understand any of that, except bloodletting, which was a treatment in Somalia sometimes. She didn't feel sick, but the doctor said she had something wrong with her. She was embarrassed and scared to ask the wrong questions, so she didn't ask what it was. The doctor left, and a lab tech came and took some of her blood. After the appointment, Najma was confused about who her doctor was. In Somalia, you only saw the doctor, but there were so many people here, and the one she spent the most time with was the nurse. Was the nurse the doctor here? Najma got a call 2 days later from the nurse, saying they wanted to test her hemoglobin and ferritin levels. The nurse also said they would send her a card telling her what foods to eat. Najma got the card titled Iron-Rich Foods. It was full of strange foods she didn't eat and didn't know how to cook. She knew some foods were used as medicine, but she didn't feel sick, and she ate good food anyway, so she threw it away. Somali doctors typically call patients to schedule follow-ups, so when the doctor never called, she decided to take it as a blessing and be done with it. Nothing helpful had come from her visit, and it had been very unpleasant. A few weeks later, Najma's neighbor got to asking how the appointment had gone. She was dismayed to hear what a catastrophe it had been. She took it upon herself to phone the office and schedule another appointment for Najma. In the interim, the entire healthcare team at Najma's clinic had attended cultural competency seminars conducted by Maine intercultural communication consultants, and they'd learn how to better treat patients like Najma by examining their own culture, learning about Somali culture, and discovering the many unexpected ways culture shapes us all. They also learned cultural bridging techniques to communicate their messages more effectively, as you'll see in a moment. This time, the receptionist gave Najma a reminder call for her appointment, and she explained that the doctor only had a short time with each patient before the next one. Each patient had to be there on time or they'd miss their spot, like you'll miss the sunset if you aren't there to see it. This was different for Najma, but it made sense. She was always on time to appointments after that. When she got to the clinic, the receptionist told Najma why she had to fill out those forms. They were for records, so the office could remember every patient over time. Sometimes doctors could look back and solve illnesses that a doctor without records couldn't solve. And if Najma got a new doctor, he or she would know all about her. She told Najma the information was confidential, which meant it could never be shared without her permission or used against her. The nurse explained her role to Najma. She was part of a big team that worked to keep lots of patients healthy. She explained why patients sometimes have to wait for the doctor. She have to wait for the doctor. She told her that some patients need extra care, or sometimes emergencies happen, but by being ready in the room, Najma could see the doctor as soon as possible. The doctor came in, and this time she explained anemia and how even Najma didn't feel sick now, it could make her very sick later. It was hard for Najma to understand being sick without feeling sick, or the idea of curing an illness in the future. But the doctor explained how they could see the causes of sickness before they were felt and before they were dangerous. The doctor said she'd like to do more blood tests and explain what could be learned from those tests. She asked Najma if that was okay. Najma's doctor provided her with another list of iron-rich foods, but this list was developed in partnership with members of the local Somali community. It featured foods that Somalis ate and could buy locally, and some recipes too. Najma recognized some of the foods as being fed to pregnant women in Somalia, and how she understood why they were good for her. Najma asked the doctor if she could be a community partner too, so she could help patients like herself understand how to get the care they needed. The doctor said that would be wonderful. Remember, no one knows everything about every culture, let alone every individual within every culture. But by increasing your cultural competency, mistakes can become opportunities for learning and authentic human connection. Working cultural competency into all levels of your practice, gaining insight into your own culture as well as others, and using the cultural bridging techniques like the ones discussed here will allow you to serve all patients with the best, most equitable healthcare possible.
So what I liked about about this clip, guys, was that it really gives a good example of sort of how we can think a little bit more about any immigrant populations that we may come into contact with, whether it's a clinic situation or even being sort of public health practitioners. And so, what I'd like to do now is shift gears a little bit and have us sort of reconvene in a few minutes. But I wanted to find out, even though the video does talk about this idea of sort of cultural bridging, I was curious about what your initial reactions were to the clip, and also if any of you guys have had any experiences working with people of different ethnic backgrounds or different religious or cultural backgrounds. It would be really great to learn a little bit more about ways you may have had communication experience working with other cultures. And I also want to know if there was any lessons or insights about active listening that you gained from this video. So I would love to hear more from you guys. And I think it would be great if you guys think you need to rewatch the video at any point. The link is in the chat, but we'll go ahead and reconvene in about maybe 5 minutes, and I'll get a sense of seeing exactly sort of what your reactions were to these questions. And we'll do as usual, we'll go in alphabetical order. So I'll see you guys in about 5 minutes. Okay, so does anyone have any insights? Does anyone need a little bit more time to think about the video clip?
I was thinking about how I've had training through UAlbany for cultural competency, but the video really stressed how different perspectives can be, even with the teenage girl saying how like she couldn't assimilate because she was so stressed from used to having to be like the mother of the family, more or less. I thought it was interesting. It brought up a lot of valid points on how to, in generally, both be a better provider and be more welcoming. Um, yeah, I use a lot of the advice or interventions activities when I work with patients or when I work on the campus because a lot of people didn't understand certain policies or what was happening or they think they were in trouble. I'm like, no, this is I'm gonna do A, B, and C and X, Y, and Z is gonna happen afterwards, and that calmed them down a lot more.
So that's definitely a good example, Catherine, of how you really took that approach to really sort of actively work with the patients and also help make them feel comfortable by simply listening to their needs. That's a really good example. Does anyone else have any thoughts to share?
So, for my job, we work with like a lot of different organizations all over the capital region, and one of them, we partnered with the West Hill Refugee Center, and my younger sister actually like runs a program to like work with the kids there, and the program just basically focuses on like a lot of like a lot of young kids when they're coming into the United States and then they're being like filtered right into like American school systems. Like a lot of the times the kids that they're in school with have gone to like preschool or like schools before kindergarten even, and they like have fine motor skills already developed or simple things like learning how to use scissors and stuff. So my sister like runs a program where they work with kids to kind of like help bring them up to speed on that type of stuff before they go into school. But what like I do with my job is we work with the families bringing in more like fresh produce into the area. But a lot of the times, like unfortunately, I only speak like English and French, so it's not helpful in the refugee center most of the time. So there is a language barrier, but there's some really amazing like translators that work with the center, and even just like trusted individuals that are like community advocates there. And so they're just like amazing resources to work with, and they're so great with explaining certain things to us or kind of teaching us ways to approach certain situations. And there's a lot of things with like me being a woman, like coming into that space, like a lot of times, like I'm not allowed to speak to some of the men or just those types of things. So it's really important to have those community connections to explain those things, because the last thing I want to do is come in with an American perspective and bias and get offended by something that really isn't it isn't meant to be offensive. And so like taking that step back and learning from people and just understanding that like there are cultures that exist outside of America, and that when you work with people, you have to always kind of keep that in mind so that you're willing to view things differently.
Thank you for sharing that, Amanda. That's a really great way to think about things because, as you mentioned, having those sort of lay health advocates and also those sort of, sort of culturally competent translators as well, that can be a really great way to help embed our interventions in a way that's actually being sort of tailored and specific to those cultures. And what your comments actually remind me of the initiative with the Refugee Community Health Partnership that Professor Russ Altone has over at the Trinity Alliance in Albany. He makes sure that he has a specific amount of, I guess you could call them bridge keepers who are part of the Karen speaking community. And they come in sometimes to help with some of the services to help people who are new to the Albany community who speak Karen understand, like, how to apply for certain social services and also how to reach out to certain healthcare providers, just like Dr. Bob Pagelo it's really good that we have translators to help be some of our stakeholders to help us with some of these goals. So I definitely am glad that you shared that, Amanda. And it really gets back to what Catherine was saying too about thinking about how even in a clinical environment, what can we do as providers to really think about how we can sort of think of making sure that all of our patients understand that we're dedicated to that level of cultural sensitivity and humility. So I'm glad that you guys both brought that up. And I was curious if Oladameji, Victoria, or Mohammed had anything to share.
Yeah. Can you guys hear me?
Yeah, we can hear you, Mohammed.
Good. Yeah, I definitely related to the entire video. I've actually, growing up, I've experienced stuff like that where my parents would have to come to me for certain helps, where whether it be for like applying to certain like social programs or going to the hospital. So I understood everything like she was portraying in the video. I think one thing there's a lot. I don't want to say a lack, but yeah, companies and organizations, should have cultural competence. But I think that they should also implement, like, for example, in hospitals where people wait in the waiting room, they should implement certain personnel that are actually that can actually like speak the language. I know that's so simple to say, like, you can find somebody who can speak them, but that's like literally what it is at the end of the day. Like, somebody can be cultural competent, but at the same time, there's certain things that they might not understand that somebody, who may be a part of that culture. Because when I say like knowing the language, I mean also being a part of that culture or sharing some kind of culture, similar culture aspects, because they have more knowledge to understand and communicate better with the individual than somebody who who has who doesn't know. Maybe they may be cultural competent, but they might not know a lot of smaller things, like what I think Amanda had mentioned, how she wasn't able to like talk to some of the men because of religious like beliefs, or if she was if it was a guy instead, and they won't be able to talk to the women because of religious beliefs. So I completely like understand exactly what, and this is not like I'm talking about from an immigrant standpoint, like for all cultures, right? Um, I think because we can always like have these discussions about cultural competency, but I think it's from experience. So when you actually go ahead and actually perform, um, or like you're interacting within these like situations, it's more about the experience, or if you can relate. I think um, to a person more so than having these monthly reviews about different cultures and stuff like that, which is still important. I'm not saying it's not important, but for like if a community is dominated by three specific cultures, and there's like one hospital in the radius of those communities, I believe we should implement some kind of structure where if there is some people like her in the video where her husband, she would go to her husband for these sort of things, and he's not around, or if you have a son or a daughter who's not around, that they don't feel scared asking for help, or they might be in fear because they're writing their name on a piece of paper. They might be fearful, but at the end, when it turns out to be just you signing your name so they can have some data about yourself. So I just feel like it's like very a lot of these things can be these problems can be solved very. It's probably simple. It might be a simple solution, but I'm pretty sure it takes it might be a lot of work to get these feats across. But yeah.
Thank you for sharing that, Mohammed, because you're right. In some ways, we really have to think about who those gatekeepers are in the community that can help bridge some of those gaps. And as you mentioned, it's one thing to have sort of like this sort of, compulsory or mandatory training every month or every quarter in cultural competence, but it really goes deeper in terms of making sure you're having consistent relationship building with people who may be in that community who are your two or three patient populations of focus that may have specific cultural norms that you really need to pay attention to. So I think that's a really important point, is that you really want to constantly be doing the work as a public health practitioner or even as a healthcare provider in a clinical setting. So you definitely make a really good point about that. And family members are definitely a very important way to think about having those liaisons between the patient and also that health literacy gap. So I think that's just definitely an important point that you mentioned. Oladameji and Victoria, did you have any comments?
Yeah, so I was gonna say that I agree with what Muhammad was saying. I kind of think my reaction is that um, if you're exposed to these types of environments where you have different cultures in a certain geographic area, you're probably going to be more likely to see or experience or have precautions in place to deal with, cross culture competencies. And I remember when I used to go to like the hospital stuff for checkups, you know I would see instructions in a multitude of languages, and I would only understand the English one. But somebody else would be probably a little more. They would probably be thankful to see those messages on the board to see where they could probably get help in in their own thing. And for me, I think language is is um, a big barrier, because sometimes you might not even understand the person completely. And the person, the secretary maybe also get frustrated because they can't really understand the person, but they really want to help. So maybe they just rush them through the process, as we saw with her, just rush them through the process. So I definitely think it's important to communicate. And I mean, I think it's going to be, I think it's just going to be based on like the experience. If you see it more, you'll be more prepared. But I think everybody, should at least every organization should at least have something like this planned, so they won't be caught off guard by something like this. But yeah, I think it's more seeing it and having exposure already, and then implementing.
Thank you for sharing that, Demeji. And Victoria, did you have any insights to share?
Yeah, so one of the scenes that just really stood out to me was when the doctor had handed the woman the high in iron food card and was like, yeah, just, have incorporate this into your diet. And it just made me think back to being in Morocco and how, like, what I know about that culture is that, like, it's different from our culture in that we'll like look up, different recipes and stuff to make, and it kind of like evolves quite a bit of like the different kind of foods that we eat. And I think that that doctor was going in with that mentality of like, oh, just like find ways to incorporate these foods into what you're eating. And my experience in Morocco is that a lot of people, like, their dishes are pretty consistent. Like there's some variety in them, but for the most part people, they have set dishes that they make a lot of the time, and like that's what's passed down generationally. And so if I were to hand a card like that to someone in my community that I lived with, they would be like, well, I don't know what you want me to do with this. Like, this doesn't, I don't know how I'm supposed to incorporate this in. And so I really liked that in the follow up after the doctor had gone through the cultural competency training, they had met with someone who like helped create an applicable food card. Because I think if we're really going to be able to help improve health outcomes with different groups of people, that's pretty essential because that's more realistic than just saying like, oh, well, we know that this food's good, so like find a way to incorporate it. And so I think that, I don't know, that scene just got me thinking about my experience cross culturally, and just in the way that we like go into a lot of interactions like making assumptions about things, especially like the nurse making the assumption that she was late because she's inconsiderate and doesn't care about anything, and not like opening her mind and asking questions of like, okay, maybe there's a reason why this person is late. So I think it's just very interesting the way that we bring our culture into all of our interactions, even with people that may have a different culture. So I don't know. I just thought that scene was very interesting to me.
To piggyback off of what you're saying about the food card, I
Mhm.
feel like a similar thing also happens when you tell people of a low SES to like eat kale or
Mhm.
include fish in your diet. Like they say, just do these things, but then their food diet doesn't
Mhm.
already have it. I've had that experience. Like my family, comes from a low SES background, so it was confusing when people or like our school organization would give us these food baskets for the weekend, but it was like quinoa, and we don't know how to cook quinoa or like what.
Mhm.
Like, I now eat it pretty regularly, but like back then it just was so confusing. It was like I don't even know what to prepare with this, and there was no further discussion about it. And then it also kind of goes into the thought, well, like, oh, you should just put healthy options places. I'm like, if someone's from like a background where healthy options aren't the default, just by putting them in your environment doesn't mean they suddenly know the recipes
Mhm.
or how to cook it or like why is it good, and that it's just frustrating.
Thank you
Yeah, no,
guys for sharing
absolutely.
that. And I think, it brings up too what Olana Meji was mentioning about sort of language and sort of this idea of having sort of these printed materials be written in a way that not just takes into account language and linguistic considerations, but also even as Victoria mentioned, if you're going to have some type of printed health education material, whether it's depicting food or even something else, it needs to sort of show examples from that type of patient's culture. And so I definitely see what you mean, Catherine, about sort of making sure that these things are done in a way that don't make assumptions about certain types of foods or customs that a community would be aware of, because you may be just infusing what you know as the provider, for example, kale or quinoa, but you're not taking into account that this may not be something that's part of your patient or client's customs. So I'm definitely glad to hear all five of you and your perspective. And I just wanted to find out if Dr. Crucetti, as a clinician, if you had any insights on this idea of cultural competence and cultural sensitivity to share.
A couple of things come to mind. First of all, I thought all the students gave really thoughtful feedback regarding the video clip. Um, One of the things that um, I was thinking about was how fortunate that woman from Somalia was to be able to at least speak English, and how much of a challenge it is when you're from a different culture and you really cannot speak the language that you're in, um, primarily English speaking clinical setting. And I think, Professor, you pointed out how Russ Saltone has worked with the refugees and has a spokesperson who can speak the language. It's a huge challenge to communicate with and through interpreters and get a good understanding about the needs of people we're trying to serve. I think about our tuberculosis clinic when I was at the health department, and we had to use an interpreter via the telephone. It took a lot of time and it was very difficult to communicate uh, what we sometimes take for granted. Okay, we're going to place a, can you tell the patient we're going to place a PPD on his or her arm? Well, many of us might know what a PPD is as a tuberculosis screening test. But when you have to then back up and say, well, this is a purified protein derivative, and it's a way to test for it, and you have to explain how it's superficial in the form, and you're doing it through an interpreter on the phone. It's an enormous challenge. And I was thinking about what you said, Professor, regarding one of our readings. Um, and I thought of the one by Rabbi Epstein. I just thought that was a terrific chapter in Oman's book. She gave examples about faith-based, faith-placed, and collaborative settings where public health educators would go into the community to discuss important health promotion issues. And in both of the readings, they talked about religion, spiritual tailoring, and RS infusion. So whatever the topic was, you need to be mindful of the background of the congregates that you're trying to reach, and make sure that you're able to communicate effectively, incorporating all of these really critical skills that we learn through cultural competence. And I think this is going to be a great segue to next week's class on health disparities. Because if you can really master the religio-cultural competences that you pointed out, then I think we'll be much more able to address health disparities that continue to be a huge problem for us in the Capital District region and throughout New York State and the country. Uh, and while I was thinking about what you had said earlier, Professor, about uh, the faith-based and faith-based activities, and the references in our readings to RS tailoring, I was wondering if when you went through your training to be a certified health education specialist, were you equipped at all with some of the principles of religion, spiritual tailoring, which was really important in both of the articles? They focused on the need to really be thinking about that and trying to bring that into whatever setting you were going to take your health promotion program uh, into, to set up shop, so to speak, and reach individuals within that community setting.
Yeah, it's interesting you mentioned that, Dr. Crucetti, because as part of our CHES exam preparation, we did have to take some courses in sort of community participatory research and also health education curriculum design. And one of the programs that was a basis for our case study to get ready for the exam actually was an initiative called Faith Moves Mountains, and it's one of the initiatives that's dealing with cervical cancer prevention in Appalachia, and it also is in the states of Ohio and Kentucky, particularly that Kentucky-Ohio border. And I remember in the preparatory course for the examination, we certainly had to learn about Faith Move Mountain in terms of understanding more about how you had these sort of faith-placed interventions at these local churches for the Faith Moves Mountain initiative. So it was interesting that we used that as the example for sort of understanding more about theory-driven health behavior change interventions. Now, luckily, the exam itself didn't necessarily have any direct sort of, sort of religious or spiritual examples in the questions, but it was nice that we at least had that example from that preparatory course because, as you mentioned, that religious and spiritual tailoring is so important. And it's unfortunate that back then, 10 years ago, you didn't have a lot of courses like the one we're taking now.
Right.
But it would have been nice if, like, those of us taking the exam could have taken a class like this one in conjunction with the different CHES preparation courses to understand how religion can actually be used to help tailor your intervention. So now that you mentioned that, I think it'll be a good idea, Dr. Crucetti, for me to link into Blackboard for this week a supplemental reading if you guys are interested to learn more about the Faith Move Mountains initiative, because it's a really good example of a tailored program similar to what we had in some of the book chapters this week.
Great.
Yeah, thank you so much, Dr. Crucetti, for that sharing those experiences. And I figured, as a clinician, you'd have the perfect sort of lens to give us some insights on that. So thank you so much for that. And I guess what we can do now is keeping among that same sort of mindset. What I'll do is also, as we prepare for the conclusion of the lecture for today, I just wanted to highlight briefly this really great sort of case study that was initiated. The first wave of it was back in 2005, and there have been some subsequent reiterations of this same study to really assess whether or not graduate medical education students, i.e. residents and fellow physicians, to what extent are they actually learning a little bit more about the whether or not religion and cultural competence are skill sets that they need to prioritize in the training. And so what I thought was interesting about this report, I'm also going to link this into the report as well, but it really talked about how, not that many residents actually reported having direct instruction beyond medical school on how to address their patients from different cultures. And what was also interesting is that, they acknowledged that a lot of the residents felt that the personal knowledge they may have or either on the job training within a clinic just simply wasn't sufficient. And so the overall outcome of some of these Tannenbaum Institute reports was really to sort of help medical and nursing schools understand that there really needs to be a better reinforcement of these types of knowledge and skill sets in terms of the hard and soft skills that students in these types of programs need to have so that they can internalize these behaviors when they interact with their patients. And the religio-cultural competence was determined to be an important investment for our next generation of 21st century physicians and also medical professionals. So, it's good that even 15 years ago, there was starting to be some sort of interest in how religion itself is placed in terms of being an aspect of cultural competence. And so if you guys are interested, I'll make sure that you guys can look at that in our Module 7 folder for this week in Blackboard. But it's just a really interesting case study, just sort of going into some of the highlights of this survey research, because they not only surveyed the resident physicians themselves and the fellows, but also they interviewed the graduate medical education office personnel, so the medical deans and the associate deans who actually determine the curriculum for a lot of these medical schools. They also assessed them to understand the extent to which they were actually providing this type of cultural competence and also religion and spirituality related subset of information to their graduate students, or I'm sorry, postgraduate medical education students. And so it's just really interesting. So if you're interested in postgraduate medical education and sort of how that relates to what we've talked about today, definitely look out for that in Blackboard. So did anyone have any questions about anything we talked about earlier in the lecture about sort of health education and health promotion, or anything in the readings before we move on to the latter part of the course? And feel free to unmute yourself if you had anything to share. Well, if no one has anything to share, feel free to just let us know by email if you have any questions. And what we'll do now is shift into the more sort of like a housekeeping aspect of the course. As you guys may know by this point, usually the last 10 minutes or 15 minutes of the class are dedicated to any relevant housekeeping in terms of assignments. And so what I just wanted to highlight was that we do have the third voice thread assignment that's still sort of, in our purview in terms of a current assignment for the class. And the goal of this voice thread assignment, unlike the other two, was instead of you guys needing to necessarily upload a slide or a PowerPoint presentation highlighting what your goal was for the final project, I think we've moved past an understanding of you introducing your idea. But at this point, the work we do in voice thread is really meant to be more collaborative in the sense of you guys working among sort of like a small group environment. And I think it's important to think about how, in some ways we have the 2 students who are doing photo voice and we have 3 students who are doing the narrative or perspective essays. So what I decided to do was split you guys into groups and voice thread. Now, the way it'll work in terms of submitting it is you'll notice that when you go to the voice thread assignments tab in Blackboard, you'll see how I highlighted that, we have 2 small groups. So one is the essay group, which I believe is group B, and the voice group is group A. And essentially what it would mean is that it's important to remember before you end up sending your responses that you click on the correct link of these two. And so I did notice that the photo groups, photo voice participants have already entered into their group. So thank you both for doing that. And we similarly have an essay group as well. So make sure that when you click on your link, you'll specifically click on this top link, which is got Catherine Mohammed and Olada Meji's name listed. This will be the link that you guys are going to click on. And so essentially what's going to happen is you're going to sort of update us about the status of where you are now. In the midterm presentations, I noticed all of you guys had some variation of a literature review that you mentioned, whether you were doing photo voice or whether you were doing the narrative essays. So in the case of those who are doing the photo voice, you know, it was really good to know a little bit more about your 6-week plans. And specific to photo voice, you know, one thing that differs from this class project other than normal photo voice is that traditionally photo voice is actually done, you know, by the people who are actually community at risk. So the people who are either at risk or in the specific community usually are the ones documenting the progress of the community through photographs. Whereas in this context, it's actually a little bit different because you guys are sort of putting on a hat as, you know, emerging public health practitioners who are actually doing photographs from a different lens as people who are possibly developing a program or a proposal. So if there were any, you know, challenges that you found so far in the methodology of your project, that's also been helpful to know with your VoiceThread project. So instead of doing any PowerPoint slides, all of you are essentially doing an audio or a video comment. So what that looks like is when you guys go into your VoiceThread, essentially what's going to happen is you're going to essentially see the little bubble and it's going to have for you guys to click submit. So let me show you the specific slide that I think will help you understand what it's going to look like when you do your VoiceThread. Let's see. Okay, here it is. Sorry about that. So this is the slide I wanted you guys to focus on as well. Was looking to learn a little bit more about specifically when you do your submission, you're going to see where this means phone comment, this means audio comment, and this of course means video comment where you would use your webcam. So when you click on the links that were in the page I just showed you, essentially when you click on these two links here, whichever group you're assigned to, what you're going to do is you're going to see this page. So what I did to make sure that I could see what you guys are saying is I did what's called the student preview mode from the instructor view. So essentially what will happen is those of you guys in the essay group, you are going to essentially click on one of these three where you can do an audio by phone or by your microphone or a webcam comment. You're going to click on one of these three and make one single reply. And you're going to do similarly where I talking about sort of the status of your project. In some cases, depending on what type of essay you decided to write, there may be people who may be key informants who actually could be helpful to talk about. So I know, for example, Catherine, you mentioned Dr. Paige Lowe as a potential, you know, sort of stakeholder or collaborator in terms of learning more about pain management. Similarly, I thought that Mohammed, earlier in the semester, you mentioned something about, I think it was your grandmother who had some really unique sort of insights about sort of her faith and also her faith-based practice. And similarly, Olada Meji, if you think that there's anyone that you can think of who can help shape some of your arguments about religion and sort of the ways that it relates to health, you know, any kind of key informants that you think of for the essay group or even for the photo voice group, anyone who you think is part of those food collaboratives or food insecurity organizations, if you think you may want to plan an interview briefly with that person, or if you've already spoken to someone who may be helpful for your project, we'd love to know about it. And these comments only need to be about maybe 3 to 5 minutes. They don't necessarily need to be exhaustive. And so once you're finished, after you click here to log your comment, essentially you're going to go up here and click on this blue button. And then that'll be what will allow Dr. Crucetti and I to get it in our inbox. And so, you know, we're really hoping that this second to last VoiceThread assignment is a way for you guys to have activity that should take you no more than 30 minutes, hypothetically, in terms of thinking about what you'd like to tell us, in terms of what you think your small group members would need to know about the status of your project. So did anyone like have any questions or concerns about this third voice thread before we move on?
So we
Yeah,
all, just to reiterate if I'm understanding this, we all comment a 3 to 5 minute video on the main voice thread on the same slide.
Exactly.
Do we comment on other people's slides or not slides, but other people's audio as well, or no?
Yeah, so actually this time around, Catherine, you don't have to do that. So this voice thread is actually different in the sense that instead of making like one reply and then having to like go back into someone else's post and then reply to them, it's actually just meant to be one reply where you're essentially giving the status update. And so the onus will be, of course, on your classmates to listen to it, but they don't necessarily have to comment to it necessarily.
Great. Okay. Thank you.
So it's a lot simpler this time around in the sense of you guys just, everyone will reply to my slide, which is this sort of green and white background. And then you're just gonna click on one of these three little buttons. And it can be webcam or it can just be a simple audio as well.
But we're replying to people in our subgroup only, right? So if me,
Exactly.
Ola, Emiji, and Catherine would be replying to each other.
Well, in the sense that you guys would all be making just one post. So this voice thread would be just one single entry by each of you. I do expect for you to listen ultimately to your other classmates, but that'll depend on who posts first and, you know.
No, what
Yeah.
I understand. I'm talking about for the second subgroup with Amanda and Victoria. You know, yeah, we'll also listen to that, but do we have to comment under theirs as
You,
well?
so you actually don't have to like view or comment on theirs. It's meant to just be those two groups.
Okay.
Yeah. So now if you'd like to, we will at some point, maybe in the fourth voice thread, come together as a group of 5. But for this third voice thread, it'll simply be just the 2-person group and then the 3-person group. So you guys in the grade book are going to be exempted from any sort of activity or viewing in that other group.
Okay.
Yeah. So I'm hoping that in that sense, you know, I think you guys got some good practice with voice thread number 1 and voice thread number 2 in terms of doing like more substantive work of like having to post a slide and comment on 2 or 3 people. But this will be much simpler in the sense of just telling us where you at right now and what kind of resources you might need from us as the instructors. You can also share that with us as well. But we're definitely excited to kind of see where things are with you guys right now. And, you know, just to shift gears a little bit into next week, as Dr. Crucetti mentioned, we are going to sort of extend upon our conversation from today and talk a little bit more about health disparities. And we're going to have a guest speaker from the Department of Epidemiology and Biostatistics, Dr. Akiko Hosler. She's actually one of the only people in the country who studies Guyanese American populations specifically at a school of public health. And she's going to join us in the early part of the lecture around 3 o'clock. She'll join us for the first 45 minutes of the class and tell us a little bit more about some of her research in diabetes prevention that she's done here in the Capital District. And so look out in Blackboard in the Module 8 readings folder. And not only are you going to see the details with the Module 8 readings that are assigned in the syllabus, but we will also send up an optional reading that you can learn a little bit more about her intervention. So that way you can understand a little bit more about her work before she joins us next week. We also, in the health disparities lecture, are going to combine some of the elements that we had in the previous course 3 years ago. At that point, we actually had a separate class session on religion and spirituality across the lifespan. So this time around, instead of having it as its own session and its own day, we're actually going to embed that a little bit into the health disparities discussion in the latter part of the course after Dr. Hosler finishes. And then also just a reminder that once you do this voice thread, the voice thread reply is expected to be submitted by this Wednesday at 6 p.m. that'll naturally transition us into the fourth Blackboard discussion. So essentially by 6 o'clock on Wednesday, you can look out for the fourth Blackboard discussion question. And essentially that'll be due 5 days later on Monday, November the 2nd. So that'll be open for you guys until midnight on Monday the 2nd. And then just a quick reminder in terms of the extra credit, as I mentioned earlier, if you are interested in having sort of more interaction with religion and spirituality in the context of health outcomes beyond this course, we definitely encourage you guys to consider writing like a mini essay or a mini debriefing of any types of interactions you may have with any events that you attend or any sort of informational interviews that you have with people related to what we've talked about in this course. Now, this can include people who were part of the panel last week. So you may remember that we posted an announcement to Blackboard with the contact information for all of those panelists. And so definitely if there was any insights that you wanted to have with them, they're all definitely very interested and willing in helping our students. And so if you decided that you wanted to have a follow-up meeting, for example, with Reverend Kyle Maillard Shop, who had to leave early, he's definitely very open to connecting with you guys one-on-one with any questions. So if you wanted to write sort of a mini essay about talking with him, for example, that's something else you could get extra credit for. And then also, if you have any informational interviews for the Photo Voice project or even for this essay project, if it's anyone that you talk to that you think can provide insights into your final project, instead of having to do a debrief within the actual project itself that you submit in December, feel free to submit sort of a one-page summary of what you talked about to Dr. Crucetti and I before that, and that can be something that we'll also consider as extra credit. And think about this as something that can add up to 3 percentage points out of the 100% points to your final grade. So we're definitely enthusiastic to see what ways you guys are able to extend your knowledge beyond just our Monday class sessions. And so keep us posted if you do end up having any events that you attend or any informational interviews that you think would be important to debrief us on so we can give you that extra consideration. So keeping that in mind, does anyone have any questions about sort of the next 4 or 5 weeks of the course, or any questions about the syllabus or anything else about where we are in the course? Well, without further ado, what I'll do is I'll let us depart for now and just look out for those Blackboard updates. And if anyone has any technical glitches with the submission of the third voice thread assignment, for example, if you don't for some reason see this blue button at the top, let me know. Similarly, if you don't see the widget buttons, or let's say it comes to Wednesday and people in your group have not yet replied and you still are, thinking of sort of questions about something that you're interested in terms of what we mean by submitting this voice thread, just keep us posted if you need any help with that. But we'll go ahead and disconnect now, and I'll see you guys next week.
Great. Thank you
Okay,
for
thank you. Have a great week.
Thank
Okay,
you.
bye guys. See you next Monday.
All right.